Minutes after. All right. Hi, I'm Sandy Werner. I'm the fellowship director at Metro Health in Cleveland. And thank you for joining us for this month's session of the Journal Club, or Probing the Literature. I shamelessly stole this lovely slide background from Dr. Durrett and Gehring. So I'll just admit that up front. So let's see. I need you to go. Okay. So just kind of how this works. So these are actually central times. For those of you who haven't joined us before, we start with a little welcome, introduce the speaker, and then we have a presentation for the first part with our author of the first article. And when we're done with that, we actually go into small groups and discuss Article 2. And there should have been a link to both articles from the sign up link. And then we kind of come back, have a group summary, closing remarks. And then for folks who can stay around and who would like some assistance with a study that they're doing or something that they're thinking about, we typically have a method consult for the next hour. And I'm not sure our real expert, Mike Gottlieb, is actually working clinically today, so he's not here. And I know a couple of us can't hang around, so we'll see what happens there. So just some brief rules. Please turn on your camera so we can see you. Please mute yourself, and then obviously unmute in the small groups. And then if you have a screen name and you can change it, just so we know not only who you are, but if you're a student, a resident, fellow faculty, and where you are too. So this is actually the first article. It's from AEM. It's the test characteristics of point of care ultrasound for the diagnosis of retinal detachment in the emergency department. And I am so happy to say that we have Dr. Dan Kim here, who's the first author on the article. And he actually, oh, come on, I keep moving my pointer thing. So Dan is a clinical assistant professor and the point of care ultrasound fellowship director for emergency medicine at Vancouver General Hospital, which is part of the University of British Columbia. So we went a little bit north today. And Dan is also, he's the chair of the Canadian Association of Emergency Physicians, kind of like ACEP, it's CAEP. And he's the chair of the Emergency Ultrasound Committee for that group. So he's into ultrasound, medical education, and strategies to make emergency medicine easier. Okay, and with that, I'm gonna turn it over to Dr. Kim.
Sounds good. So I will share my screen. Hopefully this works. Does that work?
Yes.
Okay, perfect. Yeah, thanks so much, Sandra, for the invitation, and also thank you to Michael Gottlieb for the invitation as well. I'm delighted to join you guys today. I'm coming in from beautiful Vancouver, British Columbia. If you've never been, beautiful place to visit. I highly encourage you guys to come. So yeah, we're here to discuss my paper on test characteristics of POCUS for retinal detachment. It's published in Academic Emergency Medicine, like Sandy mentioned. So why did we do this study? So, at that time, I'd kind of say sort of the highest level of evidence that existed for the use of POCUS for diagnosing retinal detachment is probably this systematic review by Prevalence, published in the Annals in 2015. And they basically identified 3 studies with just over 200 patients. And they essentially just did kind of a descriptive overview of these 3 papers and essentially came up with the sensitivity of POCUS being in the 97 to 100% range, and the specificity being in the 83 to 100% range. So I found this extremely appealing as, first of all, it seems that a normal POCUS scan effectively rules out retinal detachment. Secondly, I totally suck at using this tool, but I'm pretty good at using this tool. So I think this is essentially ultrasound it's way more intuitive really for diagnosing posterior chamber pathology, right? You toss the probe on and you can actually see, right? With retinal detachment, expect to see a hyperechoic thick membrane with minimal after movement. Posterior vitreous detachment, there's going to be a much thinner, less prominent membrane that has more after movement, and vitreous hemorrhage is going to give you this sonographic appearance of hyperechoic material swirling around in the posterior chamber. So what was our objective? The main question we wanted to answer with our study is this: what are the test characteristics of POCUS for diagnosis of retinal detachment when performed by a heterogeneous group of emergency physicians with varying degrees of ultrasound experience? And we actually used retina specialist follow-up as our reference standard. So what we wanted to do is we wanted to enroll larger numbers than previously published studies in terms of total numbers of patients enrolled and total numbers of sonographers. We wanted a larger group of sonographers instead of just having a few experts perform the scan. So our hope was that we demonstrate better generalizability by having more sonographers be a group of practitioners that looks more like your average emergency physician. So moving on to our methods. So our scanning technique, we used a linear probe in an ophthalmic setting. We had the physicians scan in both horizontal and vertical planes. We instruct our physicians to also assess the eye with dynamic scanning. Unfortunately, we didn't provide any specific guidance to our docs about how to adjust gain. Essentially, all participating physicians had to do a 1-hour didactic lecture, and then they were expected to perform one adequate practice scan proctored by a study investigator prior to actually enrolling patients in the study independently. So we enrolled a convenient sample of patients presenting with flashes or floaters or visual disturbance where the emergency physician was concerned about the possibility of retinal detachment. Patient underwent standard emergency department clinical assessment of the eye. Then the physician performed ocular POCUS, which is the test. So it's the same physician as the physician that was assessing the patient. And ultimately, all patients were seen by a retina specialist within 1 week as our gold standard or our reference standard. But of note, all patients were essentially seen by the ophthalmology resident within about 24 to 48 hours of their emergency department visit. If the ophthalmology resident diagnosed the patient with a retinal detachment or retinal tear, they were seen by a retina specialist much more urgently within 24 hours of the resident's assessment. So what did we find? We enrolled 128 patients. There were a couple exclusions. There were some patients that actually didn't make their retina specialist appointment, so we lost some to follow up. So we included 115 in our final analysis. We had a total of 30 emergency physicians enroll patients. There's, I think, a pretty good mix: 20 staff, 2 fellows, 8 residents. And our prevalence of retinal detachment was only 14%. We had 16 cases. I think if you look at the other literature that describes this, we're probably on the lower prevalence range when it comes to the number of cases of retinal detachment. So what did we find? We found that the sensitivity of point-of-care ultrasound for retinal detachment in our study, 75%, and specificity was 94%. If you look at positive and negative likelihood ratios, this translates to a positive likelihood ratio of 12 and negative likelihood ratio of 0.27. So we did a little pictogram here. It's essentially a plot of each person's POCUS scan in the order that they were performed by each emergency physician to see if there's maybe some sort of a possible learning effect based on the number of patients that you enrolled. Emergency physicians who enrolled 3 or more patients, generally speaking, had a better specificity. So they had a specificity of 98% compared to those who only enrolled 1 or 2 patients. And those people only had a specificity of 71%. I mean, you can see that, you know, amongst these higher enrollers, though, there are still a couple of false negatives and a couple of false positives. Our trainees, so our residents and fellows, they actually outperformed staff. So our trainees actually had a sensitivity of 100%, a specificity of 95%. I find in general that our trainees, who are often younger than our established staff, are usually, they seem to pick up the skill much more easily, and they seem a lot more facile with the probe, and they seem to have a knack of picking up newer applications much more easily. The cases that I was most concerned about were these 4 false negatives, essentially because, you know, you want kind of as high a sensitivity as possible to rule out the diagnosis. Amongst these 4 false negatives, one, so this is just based on comments that people wrote on their data entry sheet. So we didn't actually save or archive these images. One was incorrectly diagnosed as a PVD. One was incorrectly diagnosed as a vitreous hemorrhage. There was one patient where the doc did the scan. I happened to be at work on an administrative day, and then they thought it was negative for retinal detachment. They pulled me in because they wanted a second opinion. And, based on my scan, it looked like there was a possible detachment flap. And then it was very obvious once I just increased the gain a little bit. The last false negative, I don't really know what the error was there. So disappointingly, we were unable to replicate the very high sensitivity in the Vrabel systematic review. My sense is that, our study generally, I think, fits in the landscape of other published studies on the topic, although our sensitivity is slightly lower. Michael Gottlieb published this systematic review meta-analysis in Academic Emergency Medicine actually later that year in 2019. And they found a pooled sensitivity 94% and pooled specificity of 96%. Now we look at the forest diagram. I think our study is the sort of the last on the list. And, you kind of get a sense that we're probably somewhere in range and maybe not a total outlier. From a Bayesian standpoint, if you think about how to apply this clinically, I think that, it's actually not that bad, right? So keep in mind the positive likelihood ratio we calculated was 12, negative likelihood ratio was 0.27. Our retinal detachment prevalence was 14%. So if you apply negative POCUS, it actually brings you down to a post-test probability of around 4% or under. So, I think I'd feel comfortable with 24 to 48 hour ophthalmology follow-up for this patient. Alternatively, if point of care ultrasound is positive, it brings you up to a post-test probability of 67%. And, I think it depends on what the patient's presenting with, right? If someone says, oh, I just have a couple floaters here or there, my vision's not really affected otherwise, there's no obvious, visual field cut I'm experiencing, I don't really have as high of a suspicion or as high of a pretest clinically for that patient compared to the patient who says, oh, I got any floaters, but there's actually I have a visual field cut, or I have some, actual decrease in my visual acuity. I think automatically most of us would think that the pretest already is going to be higher for that patient than necessarily 14%. So, in my opinion, if you have a positive, that's certainly high enough to get emergent ophthalmology or retina specialist assessment. The cool thing about our study is that our ophthalmology colleagues looked at our results because they actually worked pretty closely with us on this. And they actually implemented a change to their referral form. So there's a copy of the referral form we have to fill out. We still use paper charts when we refer people. If you take a closer look at the bottom, under diagnosis, there's a specific field for PVD, and it says no evidence of retinal detachment. And they specifically say normal orbital ultrasound if completed. And this actually refers to our point of care scan. So they feel comfortable triaging these patients for appropriate follow-up within 24 to 48 hours, as opposed to, getting the patient in super urgently. The bottom line is that unfortunately all patients with new flashes and floaters, they are going to need ophthalmologic assessment in a timely manner. This rational or JAMA rational clinical series paper from 2009, right? The authors identified there's a 14% prevalence of retinal tears in patients presenting with new flashes or floaters. And in our study, we had 10 retinal tears based on the retina folks' assessment. And these are super important to diagnose because they lead to retinal detachment in maybe 1/3 to almost 1/2 of cases. All 10 of our patients who were diagnosed with retinal tears actually underwent ophthalmologic intervention, like some sort of laser procedure or something like that. And we know that POCUS is not a very good modality for diagnosing retinal detachment. So in conclusion, in a heterogeneous group of emergency physicians with varying degrees of ultrasound experience, POCUS demonstrates high specificity, but only intermediate sensitivity for the detection of retinal detachment. However, I think it's a totally reasonable tool to risk stratify your patient to determine if they need emergent ophthalmologic follow-up now versus simply timely follow-up in 24 to 48 hours. What did I personally learn from this study? If you plan on running a study that's dependent on another specialty's expertise, you really need a champion on that side to advocate for your study. So we're pretty lucky, I think, with this study. So David Maberly, who's one of our authors, he was actually the head of the ophthalmology department at that time. He's a retina specialist. He's quite supportive of this study. And we also had two ophthalmology residents, Byron Silver and Gavin Doherty, who were extremely enthusiastic about participating on their end. So we clearly couldn't have run the study without them. I think if you're interested in running a study to assess the performance of a larger heterogeneous group of practitioners with POCUS, I think you really need to consider what type of training you're providing them, how much training you provide. You know, in retrospect, I probably would have made the training for this study a little bit more rigorous. I would probably have set the bar a little bit higher for these docs. And, you know, I have been a bit more about sort of the gain settings and scanning and sort of standard gain and increasing your gain if you're not sure. But, you know, obviously there's always a challenge between trying to like balance buy-in from the group and to get as many people involved versus setting a bar that's too high or a bar that's too low. Lastly, I'd make every effort in the future, if I were going to do a study like this again, to actually have all the scans saved and archived. And I think that there's a great opportunity there to learn what the common errors, what the common mistakes are for your studies, false positives and false negatives. So thanks again for inviting me. This is my contact info, and you know, I'm happy to take any questions.
All right.
Excellent work. Thank you.
Yes.
Oh, thanks.
Thank you. Thank you. Thank you for coming. That's a really interesting study. Any questions?
On the last point, the archiving, do you routinely archive, but just didn't for research, or do you not routinely archive?
I'd say that unfortunately our ultrasound program is not as mature from that standpoint in terms of archiving. And I think that there are cultural differences too in terms of point of care utilization in Canada compared to the US. Not many places have image archiving in Canada. So unfortunately we don't. There are groups in our hospital that are working on trying to get image archiving. So this is something we're hoping that will come down the pipeline in the next couple of, like maybe the next year or two.
Wow. Wow, that is a big difference. Anybody else?
How do you feel that the Layham and Fox article from, I think it was 2019 as well, that wasn't included in Gottlieb's analysis, or obviously it was after your paper as well. They also cited, I think, like a 90s, was it 96.9% sensitivity and specificity of 88%, kind of like flipping what you found. They had, I think, twice as number total patients almost compared to this study. How does that fit into the literature in your opinion?
Yeah, I think it's hard to know exactly what the number is going to be. And I think it really, you know, as much as we'd like to say that, okay, we're all very good at using point of care ultrasound, we do know that there is some variability from individual to individual, right? Like, honestly, if I do a scan, I feel pretty confident that my own test characteristics are probably going to be almost 100%, right? In terms of sensitivity specificity. But I can't necessarily say the same about like everyone that I work with. And it may be that the baseline level of ultrasound training of the people in Layham's study was simply higher, possibly. Maybe the training that they had was more rigorous. I know that their prevalence of retinal detachments was much higher, so it might have been just like a higher risk population as well. Because like our prevalence of retinal detachment is definitely, I think, on the lower end of things. Like we were only like 14%. I think like over half of our patients ended up being diagnosed with PVD, whereas in, I think, Layham's paper, only like a quarter of those patients were diagnosed with PVD. So, you know, it may have been that we targeted a slightly lower risk population and should have kind of had sort of maybe a higher entry criteria in terms of, you know, flashes, floaters, and maybe some actual other like visual disturbance or decrease in visual acuity or something along those lines. So that I think like I said, it's hard to know what the exact number is. I think we're probably overall pretty good and probably somewhere above 90% for both. And it's just a matter of realizing, what your own personal skill set is and triaging the patient appropriately depending on what your scan shows.
Thank you.
Other questions?
Yes, I have one more basic question. First, my name is Chris Parker. I'm a UIC fellow, and fantastic study. Really appreciate the study and reading through it. Thank you for that. I was wondering, how much do you think that the time period between when you scanned the patients and when they were seen by the retinal specialist affected your outcome? And my second question is, did you look at all at comparing the results of the ultrasound that you completed and the initial evaluation of the ophthalmology residents, the test characteristics compared on that level?
Yeah, no, I mean, those are both great questions. So I'll answer the second question first. So that actually would have been a nice thing to look at, but we didn't really think about doing that specifically. So no, I don't know what the level of agreement is between what the ophthalmology residence assessment was versus the retina specialist assessment. To answer your first question about the timing to when the patient was seen by a retina specialist, I think there is a valid point that they were all seen within 1 week at maximum. I think a lot of them were seen sooner than that, but theoretically, if a person had, say, like a tiny retinal tear or something of that nature, that you would have said was appropriately a true negative on your POCUS scan, over that 1 week time period, they theoretically could have turned into a retinal detachment in that time period and become a false negative and actually driven our sensitivity lower. So we don't really know. There's no way to look back at the data to parse that out. That theoretically could have happened.
Interesting. I'm just curious because you're talking about the difference in training between the different folks and, the residents or your trainees versus the faculty. Do you look at the range of training at all as, with the false negatives and false positives? I mean, I know your residents tended to do better, but overall, had some people done just that ocular workshop, or had everybody completed an ultrasound course at some point? Or I'm just curious about the range.
Yeah, so I think with all the residents, with all the trainees, all of them do at least, I think at that point there was an introductory ultrasound course, and I think there would have been at least like a 2 or 4 week rotation for them where they were doing ultrasound.
Mm-hmm.
So like I said, they had much better test characteristics than our staff did. I think with our staff, it's hard to tell. Our system of allowing people to use point-of-care ultrasound or credentialing, I think, is not as rigorous as it may be in some of your institutions. So it's hard for me to say exactly what level of training a lot of our staff have had. Like, I think the average Canadian emerge doc has probably taken a course or had some training at some point during their residency where they would have learned basic skills like FAST, aorta, first trimester pregnancy, and basic echo. And also ultrasound guided central line access. But that would probably be the bare minimum, I think.
All right. Any other things quickly before we move on? Okay, so our next and thank you so much, Dr. Kim. That was really great. It was actually an interesting study, and it was just a terrific presentation. Thank you.
Oh, I mean, thanks for inviting me.
Absolutely.
I consider myself as someone that just dabbles in research. I'm just like a little R researcher.
Yeah,
I don't know. These methods are pretty solid. So, and
yeah.
you learned a lot of things that I've heard from excellent, top-notch researchers as well. So Yeah, I would think I would argue with that, the humility you got.
Yeah, I think it was very well done. Okay, I'm going to share my screen again really quickly. Okay. This one. All right, so our second article, there's been a lot of small studies on using the optic nerve sheath diameter to detect raised intracranial pressure. And there was a recent study that was published that was basically a literature review and meta-analyses. It was, let's see, I think it was last year. I realized I didn't put that in my little post here. But I thought that might be a good one to discuss because everybody's using it, and this gives us a little bit more information about the test. So that's the one that we're going to discuss today. And we have some moderators. We have the gang who is the sort of planning group for this, but we also have Lori Stoltz from the University of Cincinnati and Elizabeth Yetter, who's from Mount Sinai in New York. And then I know Petra Duran-Gehring from University of Florida, Jacksonville, who I stole all this lovely slide background from, is also going to be a moderator. And Dan Mersch is our technological Zoom guru, and he will divide us up into into small groups. And he put his email or his phone number up in the chat. So if anybody has any questions, it doesn't work, you wind up in Oz instead of in a discussion group, you can reach out to Dan and he can help you, because I would probably be pretty useless. Okay, so now we're all gonna put our hands on the port key and Dan is gonna take us somewhere.
Very good. If you guys have any issues with your room, feel free to just go back to the main room. If you don't like your group, just pretend it was some glitch and you ended up in the main room, and we'll make it work. All right. I'm going to open up all the rooms now.
So from each group, we'd kind of like to hear your main takeaway point. And I don't even know how many breakout groups there were. So let's see, I'm just going to start. How about if I start with Lori's group?
We were in the midst of heated discussion when we got told to come back to the room. Apparently we didn't manage our time very well. And that's okay. So we were, the thing that we were talking a lot about is that it's a well done meta-analysis and does like add to the body of literature because there's been a couple other meta-analyses on optic nerve sheath diameter, and this one is more comprehensive than some of the other ones, but it is still lacking for applicability to our practice, because these are not necessarily the patients that we have a big question mark in our heads about. These were not ED patients and patients that are getting extraventricular drains and intraparenchymal monitoring. They're patients that we don't question, do they have increased ICP usually? And so we feel like our population in the ED is an overall lower risk population and with a much lower prevalence. And so the diagnostic abilities of the test are going to be a lot different.
Yeah, definitely. And you know, these are all observational studies too, which makes it difficult. But yeah, I agree. Our total population now, if you isolated out the people with just, you know, severe, these were only the severely injured. So it's not maybe those folks that we're going to miss it on. Excellent point. Let's see. How about if we go to Elizabeth's group? And you can have somebody from your group actually. You don't have to be the key person.
Okay. Is there anybody from my group who wants to? Nope, silence. Okay. All right. Some of the interesting things that we were talking about with this is like, again, like with going back to study populations, one of the things that found kind of interesting and perhaps a little unfortunate is the fact that they didn't include people who are getting LPs, for example, for, it was a very specific population, but for a lot of us, like we use it for idiopathic intracranial hypertension or pseudotumor cerebri, whichever name you're remembering at the moment. That's where I often use this for. And I think it would have been interesting to see had a group like that been included for raised intracranial pressure, like, or just simply including LP as an option for the invasive treatments, like comparison to that.
Yeah, so not really generalizable to the applications that we might use it in. All right, let's see. Who else had a group? Dan, you have to help me out here. Oh, how about Dan's group?
We had a bunch of experts in our group. So if anybody that wants to chime in on their key thoughts from that, other than the pretty 3D diagram that we saw.
Ooh, yeah.
Today we focused a lot on technique and cutoff and how they don't describe the technique that they used. And even in our group of experts, there was like disagreement about whether the shadow that's like on the sides is an edge artifact or encompasses the subarachnoid layer, and if you're supposed to measure that. And then just how in our practice we will often see higher than 5 millimeter optic nerve sheath diameters. Kind of, I think universally for our group, that's kind of like our anecdotal evidence and trying to understand what a proper cutoff for what purpose it would be really helpful.
Yeah, and that's, I mean, it's hard to figure out, well, and also including all those studies with the various cutoffs makes it really difficult, but there aren't enough studies out there. And I would love to see a study with folks with idiopathic intracranial hypertension, which I learned as pseudotumor. I think that would be a very interesting use for this if it's accurate as a screening tool. I think that would be really, really helpful. So I'm thinking of these people who all wind up getting, either ultrasound guided LPs, or many of them wind up in fluoro because we don't have the time to do them. Or the last one I did, I sunk the 5-inch needle and I got nothing. And they went off to IR and the radiologist said, "Oh, you were in the right place. You just needed a 7-inch needle." It's like, wow. Okay, so yeah, I think that would be an excellent study. And let's see, how about your group, Petra?
I was with Dan.
Oh, you were with Dan. Oh, fine then, the group of experts. Okay, so my group, I'm gonna call on my fellow because he has to actually say something. He's being voluntold. So Greg, what was kind of our takeaway from this?
Yeah, I think the overall takeaway, we were talking a lot about how, in terms of like was kind of talked about earlier, in terms of the patient population relative to the ED patients, and when we'd be really applying this again, like patients, if we already know they have an injury or they're getting a bolt or something, how often are we really going to be measuring the optic nerve sheath? And then we talked a bit about depending on the setting, a tertiary center versus in a rural center, then it raised an interesting question of, would there be an application for, measuring the optic nerve sheath over time if you had a patient, with a known injury and say they're waiting for transport, and then you get the optic nerve sheath measurement and then, you measure it again an hour later, or there's a clinical change or something, and seeing if that will directly correlate, and kind of, interesting to see in terms of like timing, I guess in theory it should be kind of immediate that if the pressure goes up, we should see that change in measurement in the optic nerve sheath. It would be interesting to see, like, again, over time, would there be, kind of changes as you apply treatment? You give a patient mannitol, it goes down, you remeasure it. It'd be kind of interesting to see, if you could get a study like that.
Yeah. Dr. Stoner is actually going to go off and practice in rural Oregon. So this may actually be applicable, to some of the outlying places. And I was telling my group that one of the strangest consults I ever got in the middle of the night was from our just graduated fellow who was practicing in very rural Alaska, who just couldn't off the top of her head remember the maximum diameter for the optic nerve sheath. And she had a patient there. It was like 7.5 millimeters of mercury, and 7.5 millimeters. And she was like, I think that's too big. And I was like, yeah, it is. So whatever you need to do until you can fly that person out. Anyway, okay, so thank you all for participating. Some really good points and good discussion. So next month, we are going to be doing aorta and renal. Will be same time, same place, June 16th. And normally we do the second Monday or the second Thursday, but because of schedule issues and this month, because of SAEM, we've actually moved to the third Monday or Thursday, depending on which week it is. We alternate. And then, of course, if anyone is interested in moderating a small group, or if you have great articles, when you register, there's a place you can write down the articles that you would be interested in having covered. And then also, if you want to be a moderator, just email Dr. Duran Gehring, and she will add you to our list. All right.
I do want to ask one quick question from everybody before everyone leaves. In the reactions section, there's a green dot and a red dot. If you plan to change your optic nerve sheath cutoff to 6 instead of 5, hit the green button. If you're going to stay with 5, hit the red button. And I want to see what the answer is. I'm going to take a picture.
How do you do that again?
Yeah, I'm floundering.
Where's this button?
Yeah, there. So at the bottom of the screen, there says like breakout rooms, live transcript. There's a reactions with a happy face. Hit on there what you're going to do. If you're going to change to 6, use the green button. If you're going to stay with 5, use the red button. All right. Looks like there's a predominance of changing to 6. I think that's pretty interesting. All right. Well, very good. Thank you everyone for your time today. We will be doing the review session afterwards. If anyone has any research ideas they want to put forward, at least me and maybe a couple other people are going to stick around to review any possible research topics. Go ahead. Thank you.
Gotta go. Bye. Thanks, you guys.
Thanks for inviting me.
Yes,
No problem.
you.
Thank you very much for all your help today.
Hey guys.
Hell, all 3 of us are green. Look at that.
Oh, 100% I'm switching.
Yeah. Yeah. I'm also lazy and don't want to do LPs. So
There is that. Yeah.
I love LPs.
Really?
can you help
Yeah.
me? Help me.
I hate them. Yeah.
There's
Help
people
you
who
love
see the
them? I
light
think
and then
you-
there's everybody else.
I'm not like, I don't think that I'm great at them. I definitely have had a lot better success with ultrasound since I started marking out things.
Mm-hmm.
Although the last one I failed at, I did with ultrasound. And I think my problem was I didn't do dynamic guidance.
Oh, do you usually do dynamic? I usually do static.
No, I almost always do static, but this was someone that was just like, that soft tissue just like moved around. So I think where I marked her and then where she sat forward
Mm-hmm.
just didn't line up. And I really wish I'd done static or dynamic for that one.
Oh, so interesting.
So
But I
you go
almost
off.
always do static.
So if this is the spine, you're doing the off the oblique thing where like you can see
I
into this
usually
like weird
mark out
space over
the
here.
spinous process. I usually mark out the spinous process and then I go in between like normal. But I have kind of like done a little bit of that paramedian approach with how did you do that?
Yeah, I was like, what
You-
are
you could-
between
you
the
could have
transverse and spinous.
This is how I always
When I
explain
do it
like
on camera, I
spinal
was like,
stuff. It's wild, man. It's
I do
gnarly.
like the paramedian. Like I think the first couple of times I did it by accident, and I was like, oh, that's kind of cool. And then now I do it pretty routinely.
Yeah, it's still a hard procedure for me, unfortunately. Unless they're like super thin, then you know. All right. It doesn't look like Diana really has any questions. It's always great to chat though. So
What are you guys working on? Anything fun?
what am I? I've been working on surviving ACEP and
oh
not
my God.
getting hungover at Nolans. That's what I've been working on.
I was
All
gonna say,
our
I actually
interns are
feel
out
better
there.
now that I'm back, but I was like,
Well,
you're
then
gonna.
so much walking.
I'm like, I feel better now, actually.
Yeah. Well, it's a vacation too.
Yeah.
So between the walking, but man, my group parties hard, and I ain't young anymore. I'm just not young anymore.
Mm.
Yeah, they're going out till like 4:30 in the morning and then getting up in 2 hours to go do SAM stuff. And I'm like, nope,
Mm.
nope. Oh well. Good for you guys if you can still do that. I just found out I couldn't, and I was very sad.
This was the first time you found it. Well, it's been 2 years. We're deconditioned.
Oh crap! I've been recording all this.